range of clinical dosing. Be careful. I said essentially universal for safety and efficacy. It is just be careful about the term universal, because what's right for me may not be right for you or you. You know, so ultimately, medication and dosing has to be geared to the individual. But the range of dosing in the drug literature gives you an idea, gives you parameters. If you go below, it'll have no values. So it gives you an idea. And remember that the necessities for pediatric dosing and geriatric dosing, because there the parameters are somewhat different. They're modified.
I know at least where I'm living, our pediatrician was telling us that when she prescribed something, for example, said she wanted to do 20 whatever milligrams or something of Zoloft and then increase it to 100.
Right.
But then the child's insurance wouldn't pay for under 25, so she went with 25, and they would only go up to a certain amount, not to 100. So she ended up, what she was basically venting about a little bit was that she's having to prescribe around what insurance companies will pay.
And that really gets my goat. I'm being very polite about it, a polite metaphor, but that really gets my goat, that insurance companies dictate what, and by necessity, physicians and other prescribers need to do that. But it shouldn't be the insurance companies that dictate what the appropriate medication should be and what the appropriate dosing schedule of medication should be. But they do. They do dictate it. And unless you're exceedingly wealthy, unless you can afford whatever you need, we're all slaves to the insurance. I shouldn't say insurance racket. It's not professional. But we're all slaves to the insurance company. But you know something? Maybe I should say it's I hope back. If you need it, you can't. If you need it, you can't get it. If you can't get, if you don't need it, they'll give you all the insurance you need. It is a racket. It's a way to make money, and I don't think it's right.
I'm curious about drugs that you build off a tolerance to.
Right.
I have a friend who's a pharmacist who talked about a term I'd never heard before, chasing the dragon. When you have, my husband had back surgery and they gave him Oxycontin?
Oxycodone.
Yeah. And
Oxycontin is a long-acting form of oxycodone.
Okay. And he said the challenge with that drug is that you'll never get the same benefit as the first time you took it.
Right.
And so that people need to continue to take more and more of it to get the same initial effect?
Absolutely, and that's a critical concept behind addiction. What is addiction? Addiction means you need more and more to have the same effect. It's called tolerance, and you're absolutely right, and opiates are not the only kinds of drugs that produce tolerance. Is rather common. And we'll speak about that a little. If you took my course, there's a separate section just on substance abuse issues. But that's absolutely true. You're absolutely right. Opiates are notorious for building up tolerance. You need more and more to have the same therapeutic effect and to some extent adverse effect, although ultimately it is chasing the dragon, because ultimately you increase the dosage, usually illegally, you increase the dosage, and eventually you cannot escape the ultimate toxic effect, which would be coma and death. Hence, all this epidemic of heroin overdoses. That's exactly right. Exactly. It's a good point. Okay. Let's see. Pharmacokinetic. So, important determinants of dosing. Age, of course, because increasing age decreased drug metabolism, decreased rate of drug metabolism and clearance, and greater pathology. So age is always important when considering determinants of dosing. Weight. Dosing is usually measured in unit of body weight or mass. Does someone have a question? Thought I heard. I think it was a chair squeaking. In any case, weight, it's especially true in pediatric dosing. You want to know the amount of drug necessary per kilogram of body weight. It's usually dispensed with in healthy adults, but in pediatric dosing is very important. So weight. It's also important in chemotherapy, very important in chemotherapy. Chemo is measured in amount of drugs per kilogram of body weight. Race and genetic predisposition. Now, this does not imply that anyone's a racist. It has nothing to do with that, but there are certain genetic markers that come with race. For example, African Americans tend to be prone to sickle cell anemia. It's just a fact. Jewish people from the Mediterranean tend to be prone to Tay-Sachs disease, which is another genetically carried disease of the blood cells. So we can't overlook that. That is a fact. Nutrition, this is very important, especially for substance abuse counselors. Nutritional state, pathology, affects metabolism of drugs. Very often, alcoholics, drug abusers will be nutritionally compromised. When a person is nutritionally compromised, they're going to absorb, they're going to metabolize drugs different. So a person's nutritional state is very, very important. And certainly if someone is ill for any other reason, not just substance abuse, that can drastically alter the metabolism. Obviously, pregnancy, nursing, that's a determinant of dosing for obvious reasons, because many drugs are excreted in breast milk. Many drugs are excreted, I shouldn't say excreted, but many drugs are distributed through the placental vessels to the fetus, which is why, as a general rule of thumb, a pregnant woman should not be taking medication unless the benefits greatly outweigh the risks. And that's a determination only the doctor can make. I shouldn't say only the doctor, but the patient. The patient has rights too. The woman has rights too. Concomitant drug therapy. Again, I touched on this before. Always consider the effect of other drugs being taken by the patient at the same time. Always. That is why when you see the doctor, these days they're going to ask you for your list of medications. They really need to know this to make sure that whatever they prescribe is safe and will work. Another individual testing to determine the appropriate dosing, whether it's a blood or urine test. That's more true of some drugs than others. Do people know what warfarin is? The Coumadin is anticoagulant. It's very important to have the various, there's PT, but there's other blood measures too. It's very important to have essentially your clotting time taken regularly to make sure, frankly, you don't bleed to death or you don't clot to death with a stroke or heart attack. So for some drugs, regular testing, blood or urine testing, is really critical. It's a life or death issue. Psychotropic medication. People taking some psychotropic medications as Clozaril need to be blood tested regularly to make sure that the medication is not destroying the white blood cells. Clozaril, an anti-cytopenia, in other words, a deficiency of white blood cells, which in turn can lead to deadly infections, because you don't have the immune substances necessary to fight infection. So blood testing is very important. The concept of bioavailability is also important. What does that mean? You can take all kinds of drugs orally, right? You can take mass. So bioavailability is that fraction of the administered dose available to the target site, what is actually absorbed and reaches the target site. So if someone is prescribed, I'm just for the sake of argument, someone's prescribed 10 milligrams of Haldol, what good is it, and they're taking it orally, what good is it if they have diarrhea and it's most of it is passing out? So the bioavailability is that fraction that's available to the target site. That takes into account absorption, and it takes into account metabolism to the active form of the drug. It takes into account, obviously, distribution. So bioavailability is very important. As a matter of fact, genetics that are inferior may have the same active ingredient, but the amount of the active drug that's bioavailable may be less in some cases, because the absorption rate is less in inferior excipients. So keep in mind bioavailability. Obviously, more of the drug is going to be bioavailable if it's given IV or parenterally, generally. Another concept to keep in mind is what's called first pass. When a drug is absorbed, usually from the jejunum into the systemic circulation, it almost always passes the liver. It's called first pass before it's distributed anywhere else. And why is that important? That's important because the liver can, remember, metabolize, break down the substance into a worthless form, or it can change the form of the drug into an active form that binds to the appropriate receptors. So you always have to keep in mind first pass at the liver after it's initially absorbed. So, like anything else, they're individual determinants. You have to keep in mind individual bioavailability when you determine the proper rate of administration. If someone, for whatever reason, whatever pathology is not absorbing, well, then you have to think about perhaps something parenteral, something by injection. So, I mean, that's common sense, but those are the things you have to think about. Okay. Obviously, for a drug to work, its plasma or serum concentration. All blood plasma means it's the blood minus the formed elements, the cells. That's all the plasma is. And blood serum is plasma minus the fibrinogen that's needed for clotting. So that's all. The serum is thinner, obviously. So the plasma and the serum must be maintained at therapeutic levels. So that leads to the concept of the therapeutic range or window. In other words, what is the range that a medication needs to be maintained in the long run to, in plain language, to do what it's supposed to do for the patient? It's the therapeutic window, the range. And obviously, you need to correlate, it's intuitively obvious, but you need to correlate dosing with maintaining appropriate serum levels. You have to match what goes in to to the levels of the drug in the blood. Makes sense, right? Again, I already touched on this, but the loading dose is the initial dose necessary to reach the therapeutic level, the levels. Okay? That has to be considered. First, the maintenance dose is the dose needed to maintain therapeutic level over time. I wouldn't concentrate too much on VOD, but just again, the volume of distribution is the plasma concentration versus the dose administered. Really, it's just the rate at which the therapeutic level is achieved with the loading dose. How fast is the therapeutic level achieved?
I wanted to ask when some of the substance abuse clients,
right,
they take oral opiates,
right,
and they crush them,
right,
and mix them with water and inject them.
right.
So what then does that become? Would that be a first pass liver
Actually,
situation, or would that just be what happens?
actually, well, it's a little bit of both. It's not, strictly speaking, it would not be the same as first pass when absorbed from the jejunum. No, because
Because it's going into.
that's right, exactly.
Right.
So, and remember, there's no absorption necessary,
Right.
because that's going directly into the bloodstream. Eventually, it's going to get to the liver, and the liver is going to alter the chemical.
To the blood.
That's right. It's going to alter the chemical state of the initial compounds.
Mm-hmm.
But strictly speaking, you're really bypassing first pass.
Right.
Because the way we're put together, the liver is like it's like a watchdog, and that's why it, so to speak, filters toxic substances that are absorbed from the GI tract. So here you bypass.
Okay.
That's a good question. So just know that volume of distribution, and it gets technical with stoichiometry, the formulas. That's beyond the scope of this course, but just know that volume of distribution deals with stoichiometry and relates the plasma concentration to the dose initially administered. And again, clearance is important in determining the maintenance dose. Well, why is that? Why is clearance important in determining the maintenance dose? Because you got to know what's coming out before you know how fast to put things back in. Exactly. Exactly. And the half-life, again, is important for the same reason, considering dosing, therapeutic effects, and toxicity. How fast is a drug being eliminated? So, regarding maintenance dosing, the concept of steady-state dosing. The absorption rate essentially has to be equal to the clearance rate for achieving appropriate maintenance rate. It's common sense. The rate of what goes out has to be the rate of what comes in. Otherwise, it's either the drug is going to lose effect or the drug is going to build up and become toxic. So that's steady-state dosing for maintenance dosing. And again, these and now we get into pharmacodynamic effects, the action of the drug, and this is basically just a mnemonic tool, a memory tool, but pharmacodynamic, the effects of the drug on the body. The beneficial effects for the purpose of the treatment intended, therapeutic, the active treatment of disease state or symptoms, and then there's curative versus symptomatic. Antibiotics are an attempt to cure. Analgesics are totally symptomatic. Does aspirin cure? Well, I shouldn't say aspirin doesn't really cure anything, but aspirin as an analgesic is basically, it's palliative, it's symptomatic. You know, it'll lower your degree of pain, lower your pain intensity. It has some anti-inflammatory action and some antipyretic action to lower fever, but it's not really curative. It's palliative. We call that strictly symptomatic. And then you have to distinguish, as I said, between local and systemic. And then there's prophylactic therapy or preventive therapy, and you break that down into primary versus secondary. Primary, example of primary prophylactic would be vaccines, obviously. An example, what would be, do you know what an example of secondary prophylactic? It would be like someone has had a heart attack and they're prescribed statins to prevent inflammation and further cholesterol buildup, further buildup of plaque to prevent the second heart attack. So that's secondary prophylactic. I already explained about secondary effects. Certainly toxicity. Toxicity is basically an extreme case of an adverse effect where physiological function is altered to the point of being life-threatening. That's toxicity. It's usually, especially with substance abusers, it's the result of overdosing. It could be either intentional or unintentional overdosing, but toxicities usually effective overdosing. And then there's something which is strange in a way. It's an allergic or hypersensitivity reaction. That's overreaction of the immune system to normally innocuous stimuli. For example, some people, pollen is a big deal, you know. And some people, pollen can cause a life-threatening reaction. So it's usually not life-threatening, it's usually sniffles, but some things can cause life-threatening reactions. I know an elderly woman who had a life-threatening anaphylactic shock reaction. It's an extreme case of an allergic reaction to peppermint. She had sucked on peppermint all her life, but she suddenly had a life-threatening reaction to peppermint. So some things are more likely to cause allergic reactions, but an allergic reaction can happen to virtually anything at virtually any time after sensitization. You have to be sensitized the first time. After that, it can happen to virtually anything at any time. And that is why, if you read the literature, the first thing they'll tell you is a drug is contraindicated if the patient has a allergic history to either the active drug or any of its components. You must, taking a patient's drug history is critical, is absolutely critical. And there, you also have to distinguish between a more innocuous local allergic reaction, rashes are very common, to a systemic reaction. Like I said, anaphylactic shock is an extreme case. The tongues and the lips swell, your throat literally constricts to the point where you can't breathe. Your blood pressure, mean arterial pressure, your blood pressure will fall down to virtually zero, and that has to be reversed and treated. That's an emergency. Hence, you've heard of the EpiPens. Well, that's what they're used for. If it's less serious, you can take a Benadryl. You should always have Benadryl on hand in your house, always. EpiPens need a prescription. Benadryl should, because they can prevent that extreme reaction if it's caught early. Really, anyone should have a Benadryl in their house. And then there's something even stranger. It's called an idiosyncratic reaction. They're unusual, unexpected responses, peculiar to the individual, and they're not dose-related. Adverse effects are dose-related. The higher the dose, the greater the likelihood, and the more severe the adverse effect. Idiosyncratic reactions don't work that way. They're not, a little is just as bad as a lot. So they're not dose-related. It's probably individual genetic factors that are involved. And remember that natural body chemicals may affect the action of a drug. For example, alter its therapeutic and adverse effects. For example, histamines. You know, the histamines are produced in reaction to an allergen, for example. Prostaglandins, which are very omnipresent natural substances that are involved in everything. They're involved in mainly in inflammation, they're involved in absorption, they're involved in so many different kinds of prostaglandins. But the point is that natural substances affect the way that drugs work too. And how are adverse effects classified? There can be several types of adverse effects, so I'm telling you, I'm going to list the most common. Hepatotoxicity. Hepato means liver. Remember, reno means kidney, and hepato means liver. Very important, for the reasons I already mentioned. It's important due to the effects of liver enzymes on drugs and their life-threatening nature. Hepatotoxicity may affect and interfere with the actions of not only the drug that caused the toxicity, but other drugs, the way that other drugs are metabolized. If the hepatocytes become diseased, it's going to affect the enzymes that they produce. And in turn, the enzymes may either be inhibited or induced. That's going to affect the way other drugs are metabolized. You'll always see contraindications in the literature with hepatotoxicity. You'll always see that. So it's a running theme throughout drug literature. And nephrotoxicity, obviously toxicity in the kidneys, it's important because drug clearance is altered. It's usually decreased, but not always. Again, toxicity, the other drugs can develop because the blood level, if drug is not clearing, a blood level can be raised beyond its toxic threshold and be deadly. Probably the most common set of side effects are gastrointestinal side effects. They're usually not the most serious. They're usually just nuisances, but they can be serious. And that's the effects of the interaction of ingested drugs with the GI tract, although sometimes GI side effects can be systemic. In other words, a drug can bind to a receptor in the, let's say, the central nervous system or in the periphery, and that in turn can cause GI effects. Sometimes it's a direct effect of the drug while it's in the GI tract before it's exhausted. So gastric irritation, diarrhea, constipation, again, it's generally less serious and manageable, but it can be serious at times. For example, aspirin can cause what? It can cause life-threatening hemorrhaging. That's right. Exactly. Another NSAIDs, non-steroidal anti-inflammatories, can cause life-threatening hemorrhaging. That's right. And peptic ulcers. So there are some serious ones. Hematological, that just means it affects the blood. Side effects that affect the blood. There can be excessive bleeding by increasing the clotting time. It can decrease the clotting time. Potential for thromboses or clots. MI, due to a clot, that's a myocardial infarction, heart attack, or stroke. Embolic stroke. In other words, a stroke due to blockage. It can be bone marrow pathology, depression of bone marrow synthesis, resulting in decreased production of blood cells. What does that mean? White blood cells are involved in the immune system. So you decrease the production of those white blood cells, those lymphocytes, you're more prone to infection. That could be life-threatening. And then there's anemia. Some drugs can cause anemia, deficiency of hemoglobin. The body doesn't carry oxygen the way it should, and and the brain doesn't get enough oxygen, and illness, disease. And in some cases, excessive production of blood cells, usually a side effect results in deficiency of blood cells. And again, each type of hematological side effect can be life-threatening. And then the central nervous system side effects, and this is particularly important for psychotropic medication. That means effect on the brain and spinal cord, but we're more interested in the brain, central nervous system, brain and spinal cord. The common psychic effects of medications include depression, obviously. Alcohol is a depressant, depression. And sedation, which goes hand in hand with depression. Or the other extreme stimulation, which can lead to raciness, racing thoughts, and so forth. And now those have important psychiatric implications and will in your careers. What are there drugs that maybe a general practitioner, a primary care is prescribing that a psychiatrist doesn't know about, and that drug can be causing raciness. That drug can be causing depression. So they're important side effects. And then, of course, there's carcinogenicity, the capability of a drug of causing cancer. And tests are done regularly before introduction into the market, before the FDA approves. At least in theory, they should be doing those tests regularly to show potential for carcinogenicity. And then there's teratogenicity, the capability of causing birth defects. Teraton is literally a monster and comes about because some drugs, most drugs actually, usually do cross the placenta barrier and affect the fetus. Do people remember the scare with many years ago with it was actually initially an antipsychotic. Patients in Europe actually were being prescribed this particular drug, and babies were born without limbs. Thalidomide, yeah, thank you. Thalidomide was a form of phenothiazide. That's correct, was thalidomide. And that caused extreme teratogenicity. It was probably approved, at least in Europe, approved for the market prematurely. Oddly enough, thalidomide is back on the market, but you never prescribe it to pregnant women. It's back on the market because it was found to be helpful in treating cancer patients, because it works in a unique way by reducing the rate of angiogenesis of tumors expanding by producing new blood vessels. So it actually halts tumor growth by reducing the rate of angiogenesis. It's actually back on the market for different reasons, oddly enough. And then there's drug dependence, obviously, which includes addiction. This is a fine line. Substances to affect brain neurotransmitter pathways so that the patient craves or needs the drug to function. And that's broken down. It's particularly important for you. This is broken down into two types, so-called physiological dependency. I don't like these terms, but they use them. Physiological dependency is the presence of measurable withdrawal symptoms upon discontinuance or reduction of dosage. It's like the DTs, the delirium tremors, when alcohol is abruptly discontinued, or opiates. The measurable withdrawal symptoms, spasms, seizures, and so forth. That's physiological dependence. So-called psychological dependence or dependence, I don't like that term. That means the craving for obsession with a drug or drug-use stimulants are, like cocaine, are called psychologically dependency-causing. I hate that term.
Yeah, I'm up here.
I don't hate it, technically. I intensely dislike it. But I seriously, I don't like that term, because ultimately, even psychological dependence is ultimately physiological. It's just that it's the brain, and at this point, at this level of our knowledge, there are no measurable withdrawal symptoms that we could pinpoint, but it's still physiological.
Well, can you measure irritability?
Irritability, right. Irritability, well, no, you can't measure irritability, but you can observe it. You can observe it. It's some types of irritability you can observe. So there's a difference, between a symptom and a sign. Pain is a symptom. Irritability, if you have a good clinician, is a sign. They can observe it. A sign is something the clinician can observe. A symptom is something the patient feels you can't observe. So, but that's a good point. You can't quantitatively measure.
You grade skill.
Yeah, that's right, exactly.
So stimulants would those also be like your ADD or your ADHD?
That's correct, exactly,
Okay.
exactly.
So,
like Ritalin, and that's correct.
Okay, Adderall. So,
That's right.
So there would be high risk for psychological dependence.
Oh yes, absolutely. They're either class 2 or class 4 controlled substances for that reason. The risk of, in that case, psychological dependency. That's exactly right.
So why do they prescribe both? I remember a client who had both Oxycontin and oxycodone and Adderall.
Wow.
That, it's true they work different ways, but do they compete with each other at times? Do the effects oppose each other? The answer is yes. There are some cases, maybe the opiate was prescribed for pain, and the Adderall, which is an amphetamine, was prescribed for another reason, a specific psychiatric reason. But I will tell you that whoever prescribed it has to be extremely, extremely careful, or it can lead to all kinds of things. So, I think the train may be coming in now. It's just about the time for the Amtrak, for the Vermonter to come in. You should know what these terms are. I thought I heard a train whistle, that's what I said. Pharmacodynamics. indication is the proper approved usage for a drug. You should know that term. Just leave it at that. But that's what the indication. A contraindication, diseases, symptoms, conditions for which the drug will not be beneficial and usually do harm or be counterproductive. So if a specific drug you read in the literature is contraindicated for this, if Ritalin is contraindicated for mania, now you know what they're talking about. There are also off-label uses for drugs that are common. Do people know what that means, off-label? You know what that means? Okay, go ahead. It means the FDA, the Food and Drug Administration, has approved a particular drug for certain reasons. But there's some empirical evidence or epidemiological evidence, although maybe not 100% proven, that it may be useful for other reasons. A physician or any prescriber has every right to prescribe it, within reason, of course, has every right to prescribe it for an off-label use. But that being said, it is medically accepted to prescribe it that way, but that being said, beware, have in the back of your mind that the drug is being prescribed for an off-label rationale because it might not have the effect it was intended for. And drug interactions are also important. Again, one drug with another. So substance abusers abusing drugs, they're usually on several drugs, patients with psychiatric illness, elderly, they're on several drugs. Be aware of drug interactions. The interactions can be via the liver, as I've said before, the microsomal pathways, the common mechanism, again, inhibition versus induction, GI binding, I mentioned this before. A drug there can be GI binding of a drug to another drug or a substance in the GI lumen, incomplete absorption, therapeutic effect is lowered because of incomplete absorption. And then there are interactions with alcohol or illicit recreational drugs, with nicotine, and with food. Remember with food, there are some drugs that cannot, for example, be taken, like some antihypertensives, with grapefruit juice. Say, well, this sounds crazy. Grapefruit juice contains an enzyme which will actually break down the drug and render it therapeutically worthless. So there are interactions with food also. Mayo inhibitors, monoamine oxidase inhibitors. They're an older type of antidepressant. They cannot, and they're a pain in the whatever to take. And that's why they're really a drug of last resort. It's really only prescribed these days for really intractable depression that can't be treated with anything else. They're a pain in the neck because the patient has to avoid foods with tyrosine or serotonin precursors like red wine and aged cheese and so forth. They have to avoid everything like that because there can be a serious life-threatening reaction in the brain, a seizure-type reaction, if the patient is taking a so-called Mayo inhibitor, particularly in China. That's a joke. But a Mayo inhibitor, if they're taking a Mayo inhibitor with certain types of food. So there are food reactions with psychotropic medications also. So professionals must gather a complete list of all medications, absolutely necessary. They're drug-drug interactions, drug-food interactions, and drug lab test interactions. What I mean by that is certain drugs can skew lab test results, so be aware of that too. And types of interactions, a little bit more detailed. They're additive, or addition or additive effects. That means that some of the effects of individual drugs simply add up. And then there's antagonism or negation. In other words, the effects of one drug negate the effects of another drug. This is a different meaning for antagonism, but antagonism regarding drug interactions. Potentiation, that means that the total effect of each drug, when used in combination with each other, are greater than the effect of each individual drug when used alone. One drug actually potentiates the other. And then there's synergism, where And a synergism can make use of potentiation, for example. It's a positive interaction of two or more drugs. Synergism means working together. The beneficial use of two or more drugs to achieve a more satisfying therapeutic effect. In other words, for example, you use a secondary drug, which allows you to lower the dose of the primary drug. In doing that, you decrease the potential for side effects of the primary drug. Or a secondary drug may boost the therapeutic response of the first drug. So that's synergistic reaction. And now, special considerations, physiological modifications for drug effects.
Then I'm probably the only one left on it.
For example, special considerations include options for administration. You can increase dosage, you can lower dosage. That's all.
If you tell me how I can get out without setting the alarm off,
when you take it and how often.
So
there's also
I can
intuitively
leave all this.
the route of administration, oral versus rectal versus parenteral. And you all know it, parenteral.
I get a little nervous.
Technically, parenteral means par enteron, around the GI tract. So technically, a patch would be parenteral. But in medical lingo, parenteral basically means by injection. Anything given by injection is parenteral. So a dosage form is important. If a patient is actively manic, is actively psychotic, would a liquid be better or a tablet? A liquid is going to slip down easily. They can't hide it under their tongue. That's or in their buccal pouch. That's right. Sublingual would be better than having to swallow it. If he hides it under its tongue, if the patient hides it under his tongue, great. It's going to be absorbed that way. And again, selection of the particular drug or the particular drug class. What drug class do you? What will work best for the patient? Okay, I already explained that. So let's go on to page 10. The effects of aging, and it was Nicole said you work with elderly patients, right? Yeah. This is particularly important. My memory isn't that bad. I remember the code. With aging comes increase in effects of chronic disease like cardiovascular, congestive heart failure, atherosclerosis, hypertension, coronary artery disease, COPD like emphysema, respiratory and pulmonary disease, renal insufficiency, as I said before, liver disease, loss of bone mass, osteoporosis. All these effects of aging need to be taken into consideration when prescribing meds. Not only that, because of the increase in the effects of chronic disease, there's an increase in the tendency towards multi-therapy, obviously. Patients are going to be taking more medications, both prescription and over-the-counter. And don't forget over-the-counter. Just because a physician didn't prescribe it, that doesn't mean it can't affect medications the physician did prescribe. Always ask a patient what over-the-counter medications are taken to. And that goes for pediatric patients. Very often physicians forget, they don't ask the parent what over-the-counter medications the child is taking. I've seen a lot of children wind up in emergency rooms for that reason. It's very important to know what over-the-counter medication someone's taking, especially children. The physicians just forget to ask. And also, as we get older, there's a usual decline in efficient physiological function. The GI changes, urinary incontinence, hormonal changes, level of hormones decline, changes in sensory function, etc. These I'll run through because they sort of follow from what I've already said. As we age, absorption can be decreased because of decreased fluid production. So there's decreased solubility, inefficient dissolution, digestive enzyme action. We produce less digestive enzymes. Ionization is impaired as we dissolve substances. Impaired swallowing, we don't usually think of that, but there's impaired swallowing as we age. Slowing of gastric emptying, the peristalsis, the motility of the GI tract declines, decrease in absorptive surfaces. So all these things have to be taken into account. As far as distribution, decreased protein synthesis by the liver, decreased protein binding, more free drug in circulation. So a normally highly bound protein drug, the toxicity potential is going to increase. More free drug, no protein to bind. Dehydration, decreased cardiac output, toxicity potential, drugs are not going to be cleared. Metabolism is a tendency toward impaired metabolism. As we age, less sufficient degradation by the liver enzymes. The rule of thumb is, so the toxicity potential increases. The rule of thumb is lower doses for pediatric patients and for elderly patients. And obviously elimination is going to be affected, also increased toxicity potential. As we age, there's increased tendency towards adverse drug reactions, or ADRs. Why? Just normal aging, as I explained before. The increase of chronic illnesses. Number 3, increase in the number of concomitant meds. So obviously, increase in drug reactions. And this is very important. Increase in mental confusion with aging. The combination of that and the multi-drug therapy can lead to inappropriate and sometimes dangerous medications. They take too much, they forget they took it, they take it again, or they forget to take their medication altogether. So both things can lead to all kinds of disasters. So it's important to always study medication profiles. We're actually nearing an end. Again, special considerations, pediatric considerations. You have to consider physiological changes during growth and development, obviously. Weight, height, body surface area, lean body mass. To distinguish, like the body mass index, to distinguish lean body mass from amount of adipose tissue, that's actually important because of the different ways that adipose tissue and muscle tissue metabolize substances. That's important. This is constantly changing as we're growing. Generally, the greater the measurements, the greater the dosage, but it depends on the individual patient. And again, the tendency of physicians not to consider pediatric requirements, as I said before. I'll give you a very concrete example. I think I was about 5 years old, and my father was a pharmacist before me. We were vacationing up in the Catskills, and I had severe respiratory problems at that time, and there was a local doctor. He was a very young doctor, didn't know me. He prescribed, even if, any child, he obviously wasn't aware of the right thing to do. He prescribed something called aluminum chloride, which is an inorganic, it brings up phlegm. He wanted to clear the lungs of congestion. So it brings up phlegm. He prescribed a dosage that would have killed me. If my father wasn't the pharmacist, my father looked at the prescription. If he wasn't the pharmacist and caught it, he prescribed an adult dose that would have killed me. But my father caught it, and he called the physician and said, wait a minute, it's the wrong dose. You need a pediatric dose here. That's an absolutely true story. Ammonium chloride, not aluminum chloride, ammonium chloride. I apologize, ammonium chloride. That was a slip, I'm sorry. Ammonium chloride. Aluminum chloride is actually for external use only. It's an astringent or stiffing. This was ammonium chloride. Ammonium chloride is still used, but it's not used for that reason. It's used to adjust the acidity of the blood, but it's not used to bring up phlegm anymore. But that's an example. That's an example of a possibly fatal adverse effect that can happen if a physician doesn't pay attention to pediatric dosing. Let's see. And again, chronic illness at any age, renal impairment or failure, decreased clearance rates, increased blood levels, toxicity. Hepatic dysfunction, impaired metabolism, increased blood levels, reduced clearance rates, potential for toxicity. It's very, very complex. You don't need to go into it anymore, but sometimes the effect is opposite than expected. Sometimes you can have increased clearance and decreased amount of active metabolite and lack of a therapeutic effect. So beware, beware that it can work the other way too. GI absorption pathology affects the amount of drug absorbed, blood levels, therapeutic effect. Excuse me. Inadequate nutritional intake affects ADME of drugs adversely, poor absorption. Certainly, the extreme case of nutritional deficiency is hypoproteinemia. You don't see that too much in the United States, except with extreme anorexics, those hospitalized. And you see the swollen bellies of those children in Africa. And so you don't see that much in the United States, but there's still borderline hypoproteinemia. What that means is, after a certain amount of protein deprivation in the diet, the body will start drawing extremely on one's protein reserves. And the amount of proteins in the blood necessary to transport, as we said, to transport and distribute drugs, even the amount of albumin for proper osmosis to keep the amount of liquid in blood in normal stage decreases. The protein in the blood, the amount of protein in the blood dips below a critical level. That's extremely serious. The altered, as I said, the altered liver function leading to the hypoproteinemia, the liver is not producing the proper proteins for albumin and other circulating proteins, can lead to decreased metabolism. It can lead to so many different things. I remember alcoholism and illicit drug use are important because they may lead to serious adverse drug interactions and toxicities. Alcoholics, as I said before, and you all know, tend to be nutritionally compromised. And the allergic responses, idiosyncratic reactions, again, patient history is extremely important. Already mentioned, any allergic reactions are contraindications of a particular drug. Mental state, again I mentioned, is mania, psychosis may not just be an important psychiatric factor, but an important physiological factor because it can alter metabolism, decreased rate depression, increased rate mania. And again, this is extremely important. I would underline this or highlight this. Be aware of general statements. You can read all you can read in the drug literature. Ultimately, it boils down to the individual effect. The individual effect must be determined. The patient's individual effect must always be determined. If you have a patient's history, great. If not, you have to use trial and error. Sometimes there's nothing else you can do but trial and error. So remember, the patient's mental state may also affect the decision as to route of administration. Hallucinating a delusional patient may require parenteral liquid dosage. This is sort of a wrap-up. And genetic considerations, great variability in ADME factors. Again, trial and error is essential. It sounds crude. It sounds out of the medieval days, the Middle Ages, but we still rely on trial and error medication. Medicine is not an exact science. And again, it's always professional judgment as to risks versus benefits and trial and error. Choosing the drug class, individual drug, the dosage, the dosing schedule, really rely on trial and error. Okay, now the rest won't take very long. How about if you take a 5-minute break? Is that okay? And then I'll wrap up because this is a slightly different subject. So I want to. Is that okay?